Hi everyone, good morning. It's a pleasure to me to be here today, and I will present a part of my PhD, predictors of reverse ventricular remodeling in Chagas cardiomyopathy. I don't have any conflicts of interest for this presentation, and as you know, heart failure usually occurs after an initial insult, and this can lead a dysfunction ventricular. In some cases, in some patients, after you remove the initial insult or started treatment or mitral repair, resynchronization, or implant of assistant device, we can lead the patient to have a reverse remodeling and better outcomes, how we can see there, with the lower rates of mortality and the rehospitalization. Chagas disease affects 8 million people at the world, and we believe that 1.1 million lives in Brazil. Unfortunately, Chagas disease is the third etiology of heart failure in our country. And we know that this patient has a poor prognosis when we compare with other etiologies. But the studies about reverse remodeling usually include a small number of patients with Chagas disease. And we don't know the impact of reverse remodeling in patients with Chagas cardiomyopathy. Based on this background, we created our hypothesis for this trial. Reverse remodeling is associated with better clinical outcomes in Chagas cardiomyopathy and can be predicted through variables identified in this analysis. This is a pilot study, observational, retrospective, and single center, and we evaluated 1,273 charts of patients with Chagas disease and clinical diagnosis of heart failure with reduced ejection fraction. The period occurs between January 26 to December 2022. This trial was approved by ethics committees of INCOR, of University of São Paulo, and our primary outcome was survival, and it predicts factors in 16 years of follow-up in two groups. The first group is left ventricular reverse remodeling positive. The patient have the first echo with ejection fraction lower than 30% and a subsequent echo with ejection fraction greater than 30%, or who have an increase of ejection fraction greater than 10%, respecting a minimum period of 6 months between the exams. And the second group is reverse remodeling negative. These patients don't have these criteria. How we can see in this first table, we have the baseline characters of 1,049 patients analyzed for occurrence of reverse remodeling, positive or negative. We can see that we have difference between the two groups, like age, sex, NIHA classes, incidence of hypertension, infarction, and ventricular pacing contraction in 24 hours. If you look for the treatment, we can see that the usual treatment for heart failure don't have difference between the groups, but the use of furosemide was increased in the group with don't have the reverse remodeling. The comparison between the two-dimensional echocardiography, we can see that patients who have reverse remodeling positive, to back. It's here, okay. We can see that patients who have reverse remodeling positive usually have a lower left ventricular diastolic diameter and a higher ejection fraction when compared with the other group. But we don't have difference in right ventricular dysfunction. In the second echo, we can see that patients with reverse remodeling positive, there are better outcomes, better results when compared the variables. Our primary outcome was mortality, and we can see, or heart transplantation, and we can see that patients with reverse remodeling positive, there are rates of total death or heart transplantation 35%. When compared with the other group, it's about 5 to 6%. And we don't have difference between the transplantations significant between the groups. Finally, we've done the univariated and multivariated analysis of many predictors for reverse remodeling. And I want to see to you the independent predictors of multivariated analysis for long-term mortality and reverse remodeling positive. We can see that reverse remodeling positive is an independent predictor for long-term survival in these patients. And there are others, like left ventricular diastolic diameter, left atrial diameter, ureal, NIHA classes, and systolic blood pressure. And we have independent predictors of reverse remodeling positive as age, left ventricular diastolic diameter, and moderate and severe tricuspid regurgitation. Finally, I want to show to you the Kaplan-Meier survival analysis patients without or with reverse remodeling. And we can see that patients who have reverse remodeling positive, there are a median survive 11 years, and patients who don't have reverse remodeling, there are a survive 8.8 years. So, we conclude that this present study suggests that the left ventricular reverse remodeling predict a reduction in long-term all-cause mortality in patients with Chagas disease, and it's associated with age, left ventricular diastolic diameter, and moderate severe tricuspid regurgitation. Thank you for your attention.
Any questions from the audience? Joseph?
Thank you for the presentation, very interesting, large database. I guess that probably the results would be different in the recent years if you add new treatments that improve the prognostic, like ARNI or ISGLT2 inhibitors, but probably they increase the ejection fraction. But I think it's nice for the old series, because it finished in 2016, no?
Yes, finishes last year in 2022. But the number of patients with the new drugs is very short, 2 patients. So with, it's not relevant in this trial. But maybe it's a good thing for these patients, because we can see that there are a higher incidence of death. It's 50%. When we look all Chagas, not the advanced heart failure.
Chagas disease for us is very challenging because we see big hearts with big left ventricular dysfunction. And I'd like to ask for the audience, did any of you treated or saw a patient with Chagas cardiomyopathy? You did. Perfect. Thank you. Just to know.
Can I make just one comment? Maybe your question will be answered in a few years. They are doing a study in Brazil with Chagas patients with sacubitril valsartan, and the parachute study. It's ongoing.
Sure. Thank you.
Thank you.